Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Rishi Dhir from Harlow, UK. Dr. Dhir is a consultant orthopedic and upper limb surgeon at the Princess Alexandra Hospital in Harlow, UK. After completing his training in the Royal London rotations, Dr. Dhir completed fellowships in Melbourne, Australia, and the Wrightington Upper Limb Unit in Wrightington, UK. He's also CEO of Let's Talk Doctor, a unique course that trains FRCS candidates. If you've noticed, Dr. Dhir has delivered many lectures on our channel, and today it's my great honor to bring back Dr. Rishi Dhir for this wonderful live program. Over to you, Rishi.
Thank you very much, Dr. Gopalan, and hello to everybody in India. Good evening. It's really nice to be back, and also Happy New Year as well. So I'm going to talk to you guys about a topic which I think instills a lot of fear in people: biomechanic principles and also free body diagrams. So that's just my declarations. I run Let's Talk Doctor, as mentioned. So first of all, biomechanics. Before we start talking about free body diagrams, the important points are, what do you need to know for the exam? So you need to know some basic biomechanical concepts before we start, definitions. You need to be able to draw free body diagrams for each of the major joints, and you need to know about a bit of specific biomechanics for each of the joints as well. And for the sake of this talk, I'm going to focus on the first two. So let's start with some basic biomechanical concepts that you need to know for the exam. First of all, force. What is it? Okay. Force is basically a load which acts across a particular area. Okay. It's also equivalent sometimes to stress as well. So it's measured in newtons, basically. It's a load acting across a specific area. We're going to talk about Newton's 3 laws. We need to know about moments, couples, the biomechanical concept, not relationships, levers, and also a concept of equilibrium. So let's start with Newton's 3 laws. Law number 1, the law of inertia. This basically states that a body will stay static. It will not move if all of the forces and moments on it, the sum of them, are equal. Or if a body is in motion, it will remain in constant motion if everything acting on it is equal. So that's the first point, the law of inertia. The next one is the law of action, which basically states that if the forces are not equal, the body will accelerate in the direction of the force, and the magnitude of the acceleration is proportional to the force. So we use the equation force equals mass times acceleration. And then finally, the law of reaction. Every action has an equal and opposite reaction. So that means that when you walk on the ground, the force of your body is pushing down, but the ground is pushing back up at you. And that's equivalent to the joint reaction force or the ground reaction force, okay? So that's an important concept to understand. So let's move on to moments. So what is a moment? A moment is basically, it's a force acting at a distance away from a pivot. So in orthopedics particularly, we apply forces, which we call turning forces, at a distance away from a pivot or fulcrum, and that will cause things to rotate. And the equation that you need to know about is force times perpendicular distance from the pivot, okay? And the size of that moment is equal to the torque. So an analogy that I think of is, imagine you have a seesaw and you have someone who is a bigger person who weighs a bit more, and you have someone who is a smaller, thinner person. If you want to balance that seesaw, you will put the thinner person further away from the fulcrum and the bigger person closer to the fulcrum, because it's force times distance from pivot, which equals the moment. So that will help to balance the moments. As I mentioned, couples, we're not talking about relationships here, we're talking about biomechanical concepts. So a couple is literally defined as a pair of forces which is equal, parallel, non-collinear, and they act in opposite directions. So the analogy that I think of is, imagine you're driving a steering wheel. You've got one force which is acting that way and one which is acting the other way. So they're acting in opposite directions. When you open a bottle, you've got forces acting in different directions. They're equal and opposite and non-collinear, okay? But we also need to know about applications of couples in clinical practice, okay? So I'm going to talk to you about some of these force couples in action. And this is a very common one that we look at, what we call couples in the shoulder. So in the shoulder, you have the rotator cuff. Now, everybody thinks of the rotator cuff. Its function is to initiate abduction, supraspinatus, which it does, but actually its main role is it depresses the humeral head. It pushes it down and in. And that's opposed by the force of deltoid, which is pushing the head up and out. So that is known as the coronal force couple. They are balanced. And that's why if you have a rotator cuff tear, the head will rise because you've got the unopposed action of deltoid pulling it up. Conversely, we have the transverse force couple, which basically is the subscapularis force at the front and the infraspinatus or teres minor force at the back. So the internal and external rotators, and they are in balance as well. So these are called coronal and transverse force couples. So as I mentioned, what happens when this goes wrong? Well, basically, you've got unopposed action of the deltoid, so the head will start to rise, superior migration, causing erosion of the glenoid, superior and posterior erosion, which we see in rotator cuff arthropathy. And the analogy that I think of is, imagine you've got a beach ball, which is the head of the humerus, and you are trying to keep the beach ball underwater. Your hands represent the rotator cuff, pushing the head or the ball down and in, and the waves represent the deltoid, pushing the ball up and out. If your hands let go or you lose the cuff, the ball is going to rise because you've got unopposed action of the waves or deltoid. Another example of force couples that we see is in carpal biomechanics. So the lunate acts as a torque converter. It transmits a flexor force from the scaphoid and an extensor force from the triquetrum, and the two are in constant balance. So for example, if I radially deviate, my scaphoid will flex to get out of the way and allow my distal radius to contact my trapezium. And basically the whole carpus goes with it, because of the ligaments, the scapholunate and lunotriquetrum. Conversely, if I move it the other way, I ulnar deviate or palmar flex, then it will extend and the whole carpus will go with it. But what happens when that goes wrong? Okay. An example that we might see here is this PA radiograph, where you can see there is a diastasis between the scaphoid and the lunate, a so-called Terry-Thomas sign. And here what's happened is the scapholunate ligament has gone. So the chain has been broken or uncoupling has happened. So this time the scaphoid will flex, as you can see here, but the lunate will go with the intact part of the chain, the triquetrum, because the lunotriquetral ligament is still working. So the scaphoid flexes, the lunate extends, and that basically will lead to a disc deformity. So the next concept I want to talk to you guys about is levers. And what is a lever? Well, a lever is basically a mechanical system which is made up of three components: a fulcrum, a load, and a force. And the class of lever, first, second, or third, depends upon the relationship between those three parameters. So the way that I think of it is, imagine you've got a rigid bar, which is bone, and that rigid bar turns about an axis of rotation called a fulcrum. The lever basically will rotate as a result of a force from muscle contraction, and that force will act against a resistance, which is weight or gravity. And the body can be thought of as a number of different levers, okay? So let's start with a first-class lever. This is very easy. This is where the fulcrum is in the middle of the load and the force. So a use outside the body is in scissors. You've got the fulcrum in the middle, and you've got the force being applied at one end, and you've got the load which you're resisting at the other end, okay? An example in the human body, for example, might be the hip joint free body diagram or the atlantoaxial joint. A second class lever this time is where the fulcrum, so in a second and a third class lever, the fulcrum is at one end. In a second class lever, the force is further away, so it's a bit more efficient. So an example of this might be a nutcracker, where the fulcrum is at one end, the load is in between where you put the nut, and then the effort, the force, is at the other end, okay? Or an example in the human body might be the MTP joint when you're standing on tiptoes. The fulcrum is the MTP joint. The load is the weight of your heel, and the force is the gastrocnemius muscle, which is pulling. So it's a slightly more efficient lever than a third-class lever. Again, the fulcrum is at one end, but this time the force is closer to the fulcrum. It has a shorter moment arm, so it's got to work really hard to overcome that load. So the key point is a third-class lever is an inefficient lever. An example outside the body will be a sweeping of a broom, okay? Whereas inside the body, something like the elbow or the shoulder joint. So the important point to note, guys, is the majority of levers in the human body are third class, and so they are inefficient. Okay, so that's something I want you to remember. Now, the other concept that I want to mention before we start on the main topic today is this concept of equilibrium. So equilibrium basically states that all forces and moments within a system are balanced, okay? Basically, it's like, so everything on, something's meant to be in static equilibrium if everything on it is balanced. So let's move on to free body diagrams. What are they, and why do we even have free body diagrams apart from to torture residents before the exam? Because that seems to be the only time we ever look at them. So free body diagrams, it's important to know it's a biomechanical concept. It's not a real thing, it's a concept. And what you're doing is you're taking a body part and you're putting it in static equilibrium. So you are assuming that the sum of all the forces and moments acting upon that object or that body part are zero. And to draw a free body diagram, we have to have a few assumptions. And I break these down into forces, bones, joints, and muscles. So forces, we assume that the joint reaction force is a compressive force, okay? And that we've got external forces only, not internal. So there's no tension force and there's no internal forces. Bones, we assume, are rigid rods which we cannot compress. Joints, we assume, are frictionless hinges, so we don't even think about friction. And muscles, we assume that they're acting only in tension, not compression. And the line of action of the muscle is through the center of the muscle mass, and there's no antagonistic muscle actions. Those are the basic assumptions that you need to do before you draw a free body diagram. So let's move on to our free body diagrams in practice. And what I want you guys to remember before you go into the exam is they will never say to you, draw me a free body diagram just like that. They will give you a clinical scenario. And by teaching you some of these scenarios, I hope that you will be able to work out how to bring in a free body diagram or predict how it's going to be used, because they're not testing your ability to be an engineer or a biomechanical person. They're testing your ability to be a surgeon and apply these principles. That's the first important point to note. So this is how they might give you it. First of all, they might say, this patient comes to see you in clinic. Tell me what you see. So what I can see here is that, first of all, the patient is lifting up their leg on the right-hand side. So basically, their abductors or their pelvis on the left is supporting them. And what happens is they sag to the good side. So there is some sort of weakness or problem here. This is a positive Trendelenburg sign. So this is the first way that they might bring in a free body diagram for the hip. So they may ask you, what causes a positive Trendelenburg test? And everybody thinks of abductor problem, but actually I want you to think about it in terms of, is it a lever problem? Is it a force problem? Or is it a fulcrum problem? So the lever itself, if the hip is dysplastic, is going to be affected. It could be a problem with the force, either muscle or nerve, or it could be the fulcrum, the center of rotation, which would be altered if you've got arthritis or a hemiarthroplasty or a neck or femur fracture. So all those things can cause a positive Trendelenburg test, okay? The next way they could ask you a free body diagram is they could show you something like this, a very arthritic hip on the right side, reduced joint space, osteophyte formation, subchondral sclerosis, and cysts. And they could say, how can you improve the patient's pain non-operatively? Okay. So I'm going to come back to both of those clinical scenarios, and I'm going to talk to you about hip free body diagrams and how we draw them. So whenever I'm given a free body diagram, I always have a structure in my head. And this is because I always believe in an exam, if your knowledge goes to pot, if you are nervous, you need to have a system to fall back upon where you can fall back on basic principles. So I always ask myself, first of all, what class of lever is it? First, second, or third class? Where is the fulcrum or center of rotation? What are the forces or moments? And where are the levers? That's the three questions that I always ask for any free body diagram. So even if I get stuck, I can work it out. So let's start with the hip free body diagram. And I want you to make your drawings very, very simple. You're not here to be Pablo Picasso. You're here to draw a quick functional diagram. So a pelvis, a center of rotation, which is the femoral head, and a stick leg. Remember, we draw these with the patient in single leg stance. So step one, what type of lever is this? It's a first class lever because the fulcrum is in the center and we have two forces either side, a body weight force and an abductor force. So they are on either side of each other, okay? The load of the body weight and the abductors. So it's a first class lever and the fulcrum or center of rotation is in the center of the femoral head. Step two, draw in your moment arms, okay? So your moment arms, remember, they're always perpendicular to the center of rotation. So that one will act there and the abductors will act at a perpendicular. It's very important you draw it at a perpendicular. I've seen a lot of people draw the arrow in the wrong direction. So the abductors are pulling away like that, okay? Good. And then the next question they might ask you is, can you calculate the abductor force and can you calculate the joint reaction force? That's how they might start. So the first thing you say, guys, is we assume this patient is in single leg stance. And what we say is, basically, imagine that the body weight in a 60 kilogram person is 600 newtons. We assume that the weight of the leg is a sixth of the body weight. So if the patient is in single leg stance, we've got rid of this leg here, we assume that this number is 5/6 of the body weight, which is 500 newtons. And I've put some artificial values in which are a bit easy to remember. So 15 centimeters, 5 centimeters. It doesn't really matter what you use, but just some easy things where they are a multiple of each other. 5 and 15 are multiple of 3. So to calculate the abductor force, what we say is basically this number here, 500, times 15, because remember what I said, force times distance from the pivot has got to equal 5 times the abductor force. And this is what we're trying to work out. So then what we say is, if you basically divide 15 by 5, it becomes 3. So 3 times 500 is 1,500 newtons. And that makes sense because the abductors are working at a shorter lever arm. So they've got to work harder to overcome that body weight force. Now, the final bit is, can you calculate the joint reaction force? We know that this is 1,500. We know that this is 500. So the way that you do that is by a simple vector diagram. So I told you this is 500 newtons. This is 1,500 newtons, okay? Now, the joint reaction force will act in the other direction to overcome these because these are what we call clockwise moments, okay? So it's got to act in the other direction. So these add together and that joint reaction force becomes 2,000 newtons. Now, hip is the only time you may be asked to put values in. You won't be asked to put values in for any of the other ones. So it's quite easy. Just make the values something that you can easily remember. Now, going back to what we said before, I taught you guys about a Trendelenburg gate and how you could use free body diagrams in this. So what I want you guys to think about, okay, and if we annotate it, or if I draw in on here, so if we imagine basically that I've got a patient here who has, as I said before, if I draw a very simple pelvis, simple diagram here, okay, and then basically I've drawn in my fulcrum, okay, and I've drawn in my stick leg in single leg stance, okay. So this here is going to be the 5/6 body weight, okay. So 5/6. Apologies about the slightly messy drawing, but 5/6 body weight, okay? So that moment arm there, and then you've also got the abductors acting there, and it's a shorter moment arm. So what do we do in a Trendelenburg gait? Well, basically, because our abductors or our fulcrum or something is weak on that left side, we need to make it more efficient. So we need to increase. So how can we, what I say to people is, why do we have a Trendelenburg gait or a Trendelenburg test? It's because it's a compensatory mechanism. What you are doing is you are shifting your body weight over to the good side. So you are shifting the center of rotation over here. Now that will have the effect of increasing the abductor lever arm. So the abductors will become more efficient and they won't have to work as hard. And it will also have the effect of reducing the body weight moment arm. So the body weight moment will go down and the abductors will become more efficient. So your total joint reaction force will go down. So the Trendelenburg is a compensatory mechanism. That's the way to think about it. Okay, and if we move back to our other question I said, which was, how can you improve this patient's pain non-operatively? And how might you use a free body diagram for that? What you've got to think of is, you draw in your vector again. So body weight moment arm, joint reaction force, abductor lever arm and joint reaction force. These are clockwise moments. If we add in an anti-clockwise moment by putting a stick in the opposite hand, it will work in the opposite direction. So it will minus off that value and it will bring the joint reaction force down. Remember, your goal as a surgeon is to reduce arthritic pain by reducing joint reaction force. So all of these things are to try to reduce joint reaction force. So you see the same thing in a Trendelenburg test, and you see the same thing in a non-operative treatment of a arthritic hip. The third way that they could ask you about free body diagrams is they could say, show you here what's called a Charnley hip composite beam and say, explain what we mean by a low frictional torque arthroplasty. Okay, and that was what Charnley called his hip, a low frictional torque arthroplasty. So what happens here, guys, is remember, friction is equivalent to joint reaction force, and we want our hip to last as long as possible. So we want to bring down the friction or bring down the joint reaction force. So what Charnley did was he medialized the center of rotation, which is why you can see cement. He reamed out the medial wall and he did a trochanteric osteotomy to lateralize the GT. So the net effect is that that moment arm is going to increase. And so your abductors are more efficient. They're not working as hard. And so your joint reaction force and your friction will go down. So that's the two things, okay? Great. So we moved on next to the shoulder free body diagram. And again, guys, how are they going to ask you this in the exam? So they will probably show you a reverse shoulder replacement and they will ask you, how does this work? Now, before we do that, we want to first of all see how a conventional free body diagram works and then how it changes in a reverse. So conventionally, remember I said, start off by first saying, what kind of lever is this? So the fulcrum, which is the center of the humeral head, is at one end, okay? The weight of the upper limb and the weight of the hand, that is your load. That is at the other end, and in between is your force, the deltoid. So it's an inefficient lever. It's a third class lever. So step one, draw in your center of rotation, center of the humeral head. Step two, draw in your forces. So we've got the deltoid acting here and the weight of the upper limb and the weight of the hand acting downwards. Remember, this is me drawing the shoulder at 90 degrees abduction. So the diagram will change if you change the abduction. Okay. And then step three, you draw in your moment arm. So again, at 90 degrees, perpendicular to the center of rotation, you have this. Now, what happens if I change it to 60 degrees? Again, guys, don't panic. It's easy. Draw in the center of rotation, okay? Draw in your moment arms and draw in your forces and then draw in your moment arms. And again, that is going to act perpendicular to the center of rotation. And these ones here, again, will act perpendicular. So you just draw them upwards like this. And you can do that whatever angle you're working in. Okay, so that's how you draw a shoulder in different positions. Third class lever, center of rotation is in the center of the humeral head. So remember, what is the fulcrum? Draw in the forces, draw in the moments. Just think of those 3 points. So now we move on to my diagram. So what happens in a reverse shoulder? So remember what I said, center of rotation is here, center of the humeral head, deltoid, and then you've basically got the lever arm of the deltoid, and then you've got the weight of the arm, or if you're carrying a weight of the hand. Now, in a reverse, we swap the components round. So we end up medializing and inferiorizing the center of rotation. We bring it medially and we bring it down. That was Paul Gramont's principle. So this will increase your deltoid lever arm to make it act more efficiently. That's the principle of a reverse. And that's all you need to say in the exam. This is a reverse shoulder placement. It inferiorizes and medializes the center of rotation, which increases the lever arm of deltoid. It makes it more efficient. We next move to our elbow free body diagram. And again, guys, go back to my system. What class of lever is this? Well, your fulcrum is basically in your capitellum. So it's at one end of the joint. Your force is in the middle. It's brachialis, which is your main flexor of the elbow. And then the weight of the arm and the weight in your hand is the load. So that's further away. So it's an inefficient lever. It's a third class lever. So step one, draw in the fulcrum. Okay, so I've drawn in the elbow joint and the wrist joint. Okay, and I've drawn in basically the arm and then a weight in the hand. Number two is draw in the forces. So brachialis is acting upwards because it's pulling up. So that's what we call a anti-clockwise moment. And these two are acting downwards, a clockwise moment. Okay, and then finally, the joint reaction force. So the net effect, guys, is basically all 3 of those will add together. So the joint reaction force becomes compressive. So you don't need to work this out. You can just draw it as a vector. Okay, so these are clockwise moments, and the joint reaction force is also a clockwise moment. So all 3 of these will add up to be the force of brachialis. And that makes sense because if you think about it, if you put a heavier weight in your hand, let's say you were weightlifting and doing bicep curls, it's harder because you're increasing the clockwise moment. So your brachialis, your anti-clockwise moment, has to work harder to oppose that. So we can see that if somebody puts a weight in my hand or more resistance, my brachialis is working a lot harder. And also, it's going to increase the joint reaction force as well. Okay? Good. So MTP joint free body diagram. This is the one that you normally get asked for foot and ankle. Okay? So again, guys, think, what kind of lever is it? So the fulcrum is at one end. So it's either a second or a third class lever. But the weight of the heel, okay, which is the load, is in the middle, whereas the force, the gastrocnemius, is further away. So this is slightly more efficient. This is what we call a second class lever. And then we think of what is the fulcrum? It's the MTP joint, okay? What are the forces? So the body weight basically is going down. That's your clockwise moment. And the gastrosoleus is going up. That's your anti-clockwise moment. Remember the equation? Sum of clockwise moments equals sum of anti-clockwise moments because it's in static equilibrium. Okay, we then draw in our lever arms. And remember, they have to act perpendicular to the center of rotation. And then again, clockwise moment equals anti-clockwise moment. So the joint reaction force is going to be that bit there, pushing up, essentially, because it's got to equal that. The next free body diagram that they might ask you could be from a question like this, a clinical question. They could say, why do we abduct this position to lift? So why do we not have a very upright position when we lift weights? Why do we do this? And again, guys, this is a perfect opportunity to think about a free body diagram. So I'm going to lead on to a spine free body diagram. So first of all, I say, what kind of lever is it? Well, this time, the fulcrum, which is in your vertebral body, is in the center. That's the center of rotation. Your force, which is your erector spinae muscles, is on one side, and the weight of the body or a weight in your arm like this is on the other side. Okay, so for example, the fulcrum is here, erector spinae is acting away here, and weight is here. So it's in the middle, the fulcrum. So it's a first class lever. And the center of rotation is the vertebral body. This force is erector spinae. That's an anti-clockwise moment. This force, weight of the body, is a clockwise moment. Or if you have a box, you just have an extra clockwise moment. Okay? So the key thing is, how do we resolve that? Well, what we say is, if you add that together and that together, okay, I'll do that again, vertical, there, you're going to get that as a joint reaction force. And you can see now, if you add in an extra weight by picking up a box, your joint reaction force is going to increase. So how do we prevent that happening? Well, what you can do is you can adopt more of a bottom out position, I call that. Okay, so what you're doing here, you're making the erector spinae muscles more efficient, similar to what you did with the abductors, so they don't have to work quite as hard. So that will reduce the joint reaction force. So if I think about it, if my fulcrum is in the vertebral body here, okay, I'll just do that again. So if my fulcrum is in the vertebral body here, okay, and basically that is my body weight moment arm and force there, and that's my erector spinae muscle moment arm. If I adopt more of that position rather than upright position, I'm going to increase that lever arm. So I'm going to make my erector spinae muscle more efficient. It doesn't have to work as hard. Therefore, it will reduce the joint reaction force. And that's why we adopt that position to lift. Okay, so it's all about making your abductors in the hip or your erector spinae muscle in the spine more efficient. If it doesn't have to work as hard, it will reduce the joint reaction force. And that's the way to think about it. The next thing we do is move on to the knee. And with the knee, the easiest one I find to draw, guys, is the PFJ, okay? Patellofemoral joint. But how will they ask you this in the exam? Well, they might show you a patient who's had a patelectomy and ask you about the free body diagram effect of a patelectomy. Or, and the way I think about it is, so basically, if you draw a very basic free body diagram, and I can draw it on the next page, or I can show you guys here. So if I draw one here, that's my femoral condyle, that's my tibial plateau, and then that's my patella in the middle, okay? I've got a quadriceps force going here, and I've got a patella ligament force going here. So you've got an arrow there, and you've got an arrow there. Now, according to the law of a parallelogram, which I'll show you on the next page, if you resolve those forces here and here, okay, and here, that will be your joint reaction force. It will be compressive like that, okay? So that's the normal force. Now, what happens is the patella acts as a fulcrum, essentially. It's a sesamoid bone, which makes these work more efficiently. So what will happen is if the patella goes, you will essentially have the quads and the patella ligament to generate the same force will both have to work harder. So if I redraw it for you like that and like that, but this time I take the patella away and we just draw a quadriceps tendon and a patella ligament like that, that's got to work harder. So that quad force is going to go up. That's got to work harder. So that patella ligament is going to go up. It's less efficient. So as a result, the joint reaction force goes up. And that's why, guys, you can't use a normal cruise ship retaining knee for a patelectomy, because you've got greater forces going through that joint reaction forces. Basically, the PCL function becomes less predictable. So you need greater constraint, a posterior stabilized knee. So patelectomy is a perfect opportunity to bring in a free body diagram into your answer. Okay. The other way that you could bring it in is, why do you get pain in PFJ arthritis on going up or down stairs? And the way that I think about it is I draw the free body diagram. Okay. So as I mentioned, your center of rotation here, okay, is going to be basically normally in the medial femoral condyle or in the femoral condyle. So you have a quads force going up, you have a patellar ligament force going down. And then the net force, according to the laws of parallelogram, is compressive. So if your knee is just in normal 30-degree flexion when you're walking on a normal flat ground, or if you've got a straight leg, look at it. That force is just going to be a bit smaller. If I go up and down stairs, just by virtue of me bending my knee more and having a bigger angle, that joint reaction force is going to go up. And that's why in people who've got PFJ arthritis, they get more pain on going downstairs because the knee is flexed. So there is a greater joint reaction force. Okay, so that's the way to kind of think about it. So guys, that's kind of free body diagrams covered in a nutshell. So just remember, basic biomechanical concepts, you have to have a little bit of a grasp of those so you can talk about couples, moments, forces, equilibrium. Remember the assumptions of a free body diagram: bone, joint, muscle, and force, etc. And then finally, remember free body diagrams for the 6 major joints. And the way that I think about it is always linking it to clinical scenarios, because that's how they'll ask it, and that's how you will remember it as well. So if you do have any questions, guys, I'm really happy to be asked about this. This is not an easy topic to get your head round as well. And I've put just some upcoming courses that we've got coming up if you guys are interested. Or if any of you are in Chennai as well, I'm going to be at the InnovaCon on the 10th till the 12th of Feb as well. So it'd be lovely to catch up with you in person there if you're around. Brilliant. Thank you, Hitesh.
Thank you, Rishi. Rishi, you can stop sharing.
Okay.
Thank you, Rishi, for yet another brilliant presentation on the FRCS free body diagrams. I think it's entirely comprehensive, and I think the residents don't need to look into any other course material for this particular topic.
Brilliant. Brilliant. Thank you so much.
Rishi, just a few questions. Rishi, can you explain something about the Trendelenburg test and the gait, and also something called an assisted Trendelenburg test, right? Just to give some clarity for those who are watching this video.
Okay, so first of all, how do you do a Trendelenburg test? I'll try and demonstrate this by standing up. Okay, so sorry about this, guys. So if I stand up, a Trendelenburg test, you lift the leg up, but the mistake people make is they keep the leg forward like that. So to isolate it, you need to push the leg back. Okay. Now so you're lifting it up and you're pushing it back, and you need to see the patient for 30 seconds. Now, in order to keep my pelvis up and level, my abductors are working on the opposite side. If there is a problem such as a force problem with the nerves or muscles or a fulcrum, or what will happen is I will not be able to keep the pelvis up and I will fall over to the good side. And if you watch, my shoulders will go to the bad side because I'm trying to balance. Now, I used to always think, okay, Trendelenburg is pathological. But if you think about it, what you're doing is by falling over to the good side, you are shifting your center of rotation across. So you are increasing that lever arm from your abductors. So let's say I'm on my leg here and this side is the weak side. By shifting across my center of rotation, I am now increasing that lever arm. So I am making these abductors more efficient, and I'm also shortening my body weight moment arm as well. So it's actually a good thing, a Trendelenburg. It's a compensatory mechanism, because the way that I think about free body diagrams, guys, the way to remember it is, what is your goal? Your goal, okay, God was very clever. God created us all to help reduce joint reaction force, to help our joints last as long as possible. So how can you reduce that joint reaction force? You've got to bring down the body weight moment arm, or you've got to make the abductors more efficient. That's why we tell our patients as well, lose weight for hip replacement. People who've got hip arthritis, knee arthritis, losing weight works because you're reducing that body weight moment arm. A Trendelenburg gait works because you're increasing the abductor lever arm and you're shortening the body weight moment arm. A stick in the other side or an ipsilateral suitcase works because you're increasing the number of anti-clockwise or clockwise moments to basically offset that joint reaction force. So everything should be focused on bringing down that joint reaction force to help your pain. Now, what you said about the assisted Trendelenburg test, I'm not sure exactly about that. So
yeah, I remember when you ask the patient to keep his hands on your hands, you keep their hands.
Oh, okay, yes, sorry, yes, okay,
look
yes.
at the pressure, right?
Yeah, okay, you're right. So there's different ways of doing the Trendelenburg test. One is that you can basically crouch down by the patient and get them to put their hands on the shoulder. And what you're doing is you're looking at their pelvis and you're feeling for asymmetry on your shoulders. Now, I think, I shouldn't say this, but I think it looks a bit awkward in an exam when you're crouching down near the patient's groin. So I would personally do it when you're standing up as the examiner, and I would get the patient to put their hands on my hands. And as you said, we're assisting them. And then what you're doing is you're looking for asymmetry of the pelvis. Does it fall to the good side? You're looking at asymmetry of the shoulders. Do they fall to the bad side to balance the patient? And also, can you feel the weight? Sometimes if you can't see the pelvis, you can feel the weight shift on your hands. So yeah, that's I didn't know it was called the assisted Trendelenburg, but yeah, I use that. And that's probably how I'd recommend you to do it in exams, guys. Yeah.
Thank you, Rishi. I think that's all the questions that we have for this session. Thank you, Rishi, for this brilliant presentation. And I'm sure this lecture is again going to hit 10,000 views in a very short period. And really look for more talks. I get messages from all the residents, FRCS trainees in the UK requesting me, okay, please bring Rishi back. Please bring Rishi back. Okay. I'm sure you'll join us again.
In the words of Arnold Schwarzenegger, I'll be back.
Okay, bye-bye.
Okay, see you later. Bye.